Okay, in our video series of neurology lectures, in this video, we are going to talk about major neurocognitive disorder called as dementia. We are going to talk about the clinical presentation, the diagnosis, the causes, and treatment of dementia in detail. First of all, we have a case here. An 83-year-old lady is brought by her daughter who tells you that, Doctor, my mother was a school teacher. She had an amazing memory. She used to play chess, she used to play violin, she used to remember the birthday of each and every grandchildren. She used to be very happy when she met her grandchildren. But now, for the last few months, she has been very forgetful. We thought that she has this forgetfulness just because of her age. But now it is becoming more concerning. Because now she cannot even recall the names of her grandchildren. She cannot identify her grandchildren. She seems very unconcerned when she sees them. She used to go to grocery store near our home, and every day she brings the groceries from the store. Now, 2 days back, she went there and she forgot the way back home. And she was lost in the same vicinity that she used to travel for many years. She could not remember the path way back to the home. She was found in the park 4 hours later. But when we brought her home, she was quite unconcerned that this episode happened. She looks depressed as well. Doctor, what is wrong with my mother? This is a case of dementia. How does dementia present? What are the causes? And how would you manage it? Today we are going to talk about that. Dementia is a progressive decline in the cognitive functions, including memory. The memory is lost. Executive functions, the ability to execute a certain thing, going to the grocery stores, buying the groceries, and coming back home. Language skills, these patients forget the language they speak and they replace them with abnormal wrong words. Problem solving skills, playing chess, playing puzzles, solving crossword puzzles, severe enough to interfere with the daily life and independence. When it progresses to a severe form, the patient even forgets how to maintain the normal cleanliness, how to change clothes, how to button up the shirt. Even they forget how to eat, how to chew the food. This is how dementia affects a person. Now, it is very important for you to know that with age, a person gets a memory loss, and that memory loss with age is normal. But that memory loss is up to a certain extent. In dementia, it is abnormal. The memory loss in dementia is so severe that it affects the daily life, and it is an abnormal thing that needs to be investigated and treated. Dementia is abnormal. It needs treatment, while normal aging is a normal process. Now, how will you differentiate that whether the patient is having a normal aging memory loss or dementia? In normal aging, the patient will be concerned that, Doctor, I have this memory loss. I forget where I put my keys. I forget the birthdays of my grandchildren. I forget the names sometimes. The patient will come to you and tell you all these problems. While in cases of dementia, the patient is unconcerned and the family will bring the patient and tell you, the doctor, our father is forgetting many things now. Our father forgets the way back home. Our father forgets the very basic things that he used to do. Our father has forgotten how to play chess. Our father used to play violin, but now he cannot play that. Our father cannot even remember his grandchildren. The family will be concerned, but the patient will be unconcerned. That patient would not come to you. That is dementia. That is how it is different from normal aging. In normal aging, the patient remembers the details of forgetfulness. The patient will tell you, the doctor, I set an appointment to meet a certain person at 3 p.m. of the day, but then I totally forgot that I had set a meeting, or I placed a keys somewhere and I totally forgot where I have put those keys and I am unable to find them. He remembers the details of forgetfulness. While in patients with dementia, they do not remember any details. They are totally unconcerned about the memory loss. They don't even know that they have memory loss. In normal aging, the recent memory is intact. During the conversation, when you are talking to the patient, if you tell your name in the beginning of the conversation, the patient will remember that name and patient will know that he is here with a doctor and talking about this memory loss. While in patients with dementia, when they are brought to the doctor, they don't even remember that they are with a doctor or in a hospital setting after some time. After a few minutes, they would totally forget that they are in a clinic with a doctor for the problem of memory loss. So they have a recent memory loss, while normal aging patients will have do not have recent memory loss, their recent memory will be intact. In severe cases of dementia, these patients also have receptive aphasia, where you tell them to do a certain thing and they won't be able to understand that language that you are telling them. In normal aging, there is forgetfulness, but the patients are independent in activities of daily life, like wearing clothes, keeping themselves clean. While the patients of dementia, they have much forgetfulness, they have so much memory loss that they become dependent for activities of daily lives, for defecation, for urination, for clothing up, for buttoning up. They need help because they do not remember that these certain important things need to be done in a certain proper manner. Therefore, dementia is a very severe condition where the patients become dependent on the activities of daily life. Patients of normal aging maintain the social skills. They know that if they are in a wedding, they have to be happy. If they are in a funeral, they have to be sad. So they get the social cues and they maintain the social skills. While in the severe cases of dementia, these patients will look very unconcerned. These patients won't understand that what occasion is going on and how do they need to act. They will look like they are normal. Even in the initial stages, they would sit with you. When you say hello to them, they would nod their head, but their demeanor will be normal, but they won't understand what is going on. So the dementia patient has loss of interest in the social activities. So this is very important for you to understand that dementia is not normal. Dementia is abnormal loss of memory, and you need to differentiate it from normal aging. Normal aging is a normal loss of memory with age. Now, whenever you have a patient of dementia, it's very important that you find out the cause of dementia. In majority of the cases, in almost 70% of the cases, Alzheimer's disease is the most common cause of dementia. We are going to talk about each and every cause in detail. We are going to discuss the diagnosis and managements in our video series of neurology. Alzheimer's disease is the most common cause of dementia. Vascular dementia, dementia with Lewy bodies, frontotemporal dementia, Parkinson's dementia, Wernicke's encephalopathy, Wernicke's-Korsakoff syndrome, late neurocephalus, Creutzfeldt-Jakob disease, progressive multifocal leukoencephalopathy. So these are all the causes that we are going to explain ahead. Cardiovascular disease, also called as vascular dementia, multi-infarct dementia, where the vessels are damaged, therefore the brain gets ischemia and the patient gets memory loss. Normal pressure hydrocephalus, inflammatory or infectious conditions like syphilis, HIV can cause dementia. You can remember a simple mnemonic, dementias, to remember all the causes. D for degenerative causes like Alzheimer's, Parkinson's disease. E for emotional, depression and psychosis. Remember, depression causes pseudodementia. What is pseudodementia? I'll talk about that. Metabolic causes like liver or kidney failure, endocrine, hypothyroidism can cause dementia. Nutritional vitamin deficiencies, neoplastic conditions, normal pressure hydrocephalus. T for traumatic. I for infectious, syphilis, HIV. A for autoimmune diseases, and S for stroke. So dementia is an easy mnemonic for you to remember the causes of dementia. Now coming to the clinical presentation, it will be quite obvious for you now to understand that what will be the clinical presentation of these patients. These patients will have impairment of memory. Makes sense. These patients will have aphasia. These patients will slowly and gradually have problem with the speech. They will forget the words. They will have word finding difficulty. They won't have the words to describe the thing. Therefore, they will get more silent with the passage of time. These patients will have semantic paraphasia. They will replace one word with another word and they won't even know that they are saying it wrong. If they see a dog, they would say that it's a cat and they won't even feel that they have said a wrong thing. While a patient with normal aging would, if he says the word cat for a dog, he would know that something is wrong. Like the exact word I do not remember, but something related to the cat. So a normal aging person will have the insight that something is wrong. They will have loss of intellectual capacities. Like if they are going to a grocery store, they forget that they have to make a list of each and everything that they have to buy. They forget to even take the money with them. They forget that they have to use car to go to the grocery store. So these are the reasoning, the planning and self-control is lost in patients with dementia. These patients will have apathy, where they will have loss of interest and loss of enthusiasm in doing activities. These patients will have spatial temporal awareness loss, which looks like a difficult word, but it means is that these patients will not be spatially aware. If they are driving, they won't be aware that they have to drive in a certain lane so that they do not collide with another car. They would get collision of the car and they would be totally unconcerned that their car collided with another car. So, or if you throw a ball to them and naturally people catch the ball, they won't be even aware that they will have to catch the ball, and they don't even know that how to catch the ball. So that level of memory loss takes place in these patients. These patients will be brought by the family, and the family would tell you that, doctor, our father used to be a very good player of piano. He used to play in orchestra, and now he doesn't even identify the piano when it is placed in front of him. That is the level of memory loss in dementia. These patients will have apraxia. Apraxia means loss of visuospatial skills like buttoning up the clothes. These patients will have agnosia. When you show them a bicycle, they would say that this is the tire, this is the pedal, but when you ask them that what is the purpose of this thing, they won't even know that this is bicycle on which you ride and you go from one place to another place. These patients have a nosoagnosia, where they do not even remember, where they do not even have the insight that they have a memory loss, they have a problem. So these are difficult words, but if you know the meanings, they become very easy for you. These patients will have changes in personality, mood, behavior. In the early stages, they will be having depression, apathy. If there is a, let's say, party going on, they will be sitting there in one corner, and when you see them, you will feel that they are totally normal, but even if you say hello to them, they will nod their head. So they maintain a social demeanor until unless when you talk to them, when you start talking to them, you would tell them your name, and 2 minutes later they will ask you again, what is your name? You tell them that you are a doctor, and 2 minutes later they would ask you that what do you do? So they have this severe memory loss that when you are talking to them in a conversation, they do not remember what conversation they are having. So they maintain a social demeanor. From outside, they will look that they are normal, but they are not normal. They have this severe memory loss. Now, remember, there is a condition called as pseudodementia, which occurs due to depression. Remember, depression is a common thing in old patients. Depression would cause memory loss in old patients. Depression would cause them to be having loss of enthusiasm, loss of interest in activities. And with depression in old patients, there is severe memory loss as well. But that memory loss due to depression is reversible. When you treat it with antidepressants, these patients get totally better. When you treat the depression, the memory loss goes away. Therefore, it is called as pseudodementia. Whenever you have a patient with dementia, you have to screen that patient for depression, because if it is depression causing the memory loss, then this is pseudodementia. The real dementia is different. Pseudodementia occurs due to depression, and patient can recall the onset of symptoms, and it is responsive to the treatment with antidepressants. When you ask questions from these patients, the patients who are depressed, they will give short answers. They will say, I don't know what is going on with me. When you ask them, do they feel that they are having forgetfulness, they will just simply say, I don't know. So these patients are to be screened for depression, whoever presents with memory loss, because depression can cause acute memory loss and it is responsive to treatment. Therefore, it is called as pseudodementia. Now, coming to the diagnosis of dementia. In the diagnosis of dementia, it's very important that you take a history, a detailed, thorough history of the memory loss to differentiate whether it is normal aging loss or it is a dementia. You have to perform a thorough neurological examination to rule out cerebrovascular accident in these patients. You perform certain tests called as mini mental state exam or mental status exams. Cognitive assessment is done in these patients. We are going to talk about all of them in detail. And you also review the medication. Certain medications can also cause memory loss and confusion in the patients. That is called as Beer's criteria. You can check out the Beer's criteria on the internet, what medications can cause confusions in old patients. You have to rule out reversible causes like pseudodementia. A patient with depression can present with memory loss. Rule out pseudodementia. Rule out delirium. Remember, delirium is different from dementia. Dementia is a permanent memory loss, while delirium is acute memory loss for some period of time due to a metabolic abnormality going on in the body. For example, a patient is having a urinary tract infection, and after urinary tract infection, the patient now has developed confusion. The patient is not getting out of the bed. The patient is disoriented in time, place, and person. But as you treat the urinary tract infection, the confusion goes away and the patient is totally back normal. So that acute episode of confusion would be called as delirium. due to a metabolic abnormality. While dementia is constant, dementia is progressive, dementia is permanent. You have to do certain lab tests like vitamin B12 levels to see whether this is vitamin deficiency that is causing dementia. You have to rule out hypothyroidism. You have to do complete blood profile, metabolic profile, liver function test, renal function test, glucose levels to rule out any metabolic causes that might be causing delirium. You have to do urinalysis because remember, UTI, even asymptomatic UTI, is a very important cause of delirium in patients, acute confusion in these patients. You have to do virology in these patients like HIV. And then after doing all these metabolic causes, you do the neurological examination, you do the cognitive assessments, you do the mini mental state exams, you perform the lab test, you rule out pseudodementia, you rule out the metabolic causes that might cause delirium. And then at the end, you go for brain MRI. A brain MRI is a preferred imaging modality, and according to the cause, like from Alzheimer's to the frontotemporal dementia, Creutzfeldt-Jakob disease, these all causes have a certain presentation on the brain MRI, and we are going to discuss each one of them thoroughly in our video series. A common presentation in all these conditions is that there will be brain atrophy. Other tests that can be performed include ANA, RPR. If you get a hint that that patient is having syphilis or any autoimmune condition, or the patient is having Wilson, ceruloplasmin level is done, Lyme disease, Lyme titers are done, EEG is mostly normal or shows slow activity in patients with Alzheimer's. So according to the cause, you further investigate whatever hint you get on the examination. According to that, you do further investigations to find out the cause of dementia and memory loss in these patients. A patient of dementia is assessed by history, neurological exam, brain imaging, and cognitive assessment tests. Those cognitive screening tools include clock drawing test, mini mental state exam, Montreal cognitive assessment test, MOCA, St. Louis University mental state exam called as SLUMS. So these are different methods, screening tools that are used to identify a patient has dementia or not. The most famous one is the mini mental state exam. Clock drawing test is a cognitive screening tool used in combination with other screening tools, in which you give a piece of paper on which there is a round circle drawn, and you tell the patient to draw a clock, write down the digits, and to point to a certain time like 15 past 6. So when you tell them to draw a clock, these patients of dementia are unable to draw it, or when they draw the clock, they write down the digits in a wrong manner. They write down the digits either on totally on one side, or they write the digits haphazardly, or they are unable to even draw the digits properly. So that shows that these patients are unable to remember the structure of the clock, which is a very basic thing that they have been looking at throughout their life. Clock drawing test is used in combination with other tests. Mini mental state exam is a very famous screening tool used for dementia screening, and there are 30 sets of questions that are asked, whether the patient is asked what year it is, what season it is, the day. They are asked to spell the words backward. They are asked to repeat certain phrases. They are told 3 different things, and they are asked to repeat them after some time. They have to say a certain sentence that has nouns in it and verbs in it, so you can read it thoroughly, and scoring is done. If the score is less than or equal to 24, it means the patient has dementia. If it is 21 to 24, it is mild dementia. If it is 10 to 20, it is moderate dementia. If it is less than 10, then it is severe dementia. Now, it is very obvious that educational level can affect the cognitive assessment, because if the person is more educated, that patient will perform well on mini mental state exam while still they are having dementia, while uneducated person will perform poorly on mini mental state exam. So educational level affects the use of these cognitive tests. Now coming to the treatment of dementia. In the treatment of dementia, it depends upon the cause. What is the cause of dementia? Whether it is Alzheimer's, whether it is frontotemporal, whether it is Parkinson's, whether it is Huntington's. And according to the cause, you treat them. We are going to talk about the management of each one of these in our coming videos. In this video, we are going to talk about the supportive care management that you can provide to a patient with dementia patients. Familiar home environment should be given so that they remember each and everything. Exercise, sleep, and diet should be taken care of. Cognitive training, cognitive stimulation should be done in these patients, like activities like crosswords, puzzles, so that the brain stimulation is there. Advanced care planning must be done as soon as they are diagnosed with dementia, because these patients will develop further memory loss and the memory will further degrade. If they are able to make a decision about the advanced care, you should discuss these things with them. If these patients develop depression, anxiety, you give them SSRIs, escitalopram, escitalopram. These patients of dementia would frequently get agitated, they would frequently get very aggressive, which is very common seen in the wars. But you should use non-medicine de-escalation methods. Avoid giving antipsychotic to these patients. If it is very necessary, you can use citalopram. Citalopram has also shown to reduce aggression in patients with dementia. Or if needed, low dose antipsychotic can be given. Risperidone is a preferred one. Otherwise, avoid antipsychotics. Now, in the supportive care, I remember an incident when I was working in dementia ward. We had a very big poster of a park, a picture of park that was posted on a wall. And in front of the wall, there were some benches that were placed. And in that poster, there was also written bus stop in front of the park. So every day the patients of dementia would pack their bags and they would come and sit on those benches and wait for the bus to come so that they can ride the bus. And every day they used to forget that, and multiple times they would pack their bags, come and sit there, keep waiting, and then go back, and then they forgot that this bus doesn't come anymore and this is just a poster. So these are some soothing techniques, some techniques to reduce the aggression and agitation and psychosis in these patients. You have to avoid anticholinergics, TCAs, diphenhydramine, because they can result in confusion, they can result in worsening of the memory loss, and they can also cause dry mouth and symptoms in these patients. Avoid dietary restrictions. These patients of dementia, you don't need to be very strict on the diet. Whatever they like, even if they like custard, if they like ice creams, you should give whatever they want to eat. In severe dementia, it's important that you avoid tube feeding rather than passing an NG tube and giving food through them. It's a natural process. Oral feeding by hand is preferred. Even if they stop eating, they forget how to eat, it's not important that you pass an NG tube and start feeding them. It's a natural process. You should tell the family that it's a natural process that they stop eating, and it's a process of dying in these patients. So avoid aggressive measures like passing NG tube and feeding them. If they stop eating, it's totally fine. You can provide oral feed for some period of time, but even if they stop chewing food and they don't even know how to swallow the food and the food is drooling down, it's fine. You can stop and tell the family that this is a normal process of death in these patients. Avoid catheterization in these patients. Now, before going into the summary, if you liked my video, please click on the subscribe button and make sure to check out my rest of the videos on Alzheimer's, frontotemporal dementia, Lewy body dementia, vascular dementia. I have explained them in detail in my neurology lectures. Also check out my lectures on ECG, emergency medicine lectures, infectious disease medicine lectures. In this video, we talked about what is dementia, what is the difference between normal aging and dementia, what are the etiologies, what are the different presentations of dementia, what are the different changes in late stages, what is pseudodementia, how do you proceed for the diagnosis of dementia. MRI is a very important component, cognitive screening test, mini mental state exam is a very important one. Education level affects the use of these tests. Treat according to the cause. Supportive care should be given. Avoid antipsychotics in these patients. Avoid anticholinergics. Don't go aggressive on feeding. If you like my video, please click on the subscribe button and make sure to check out the rest of videos in this neurology series. Thank you very much.